That's time to start. No, you're fine. I just want to make sure our audio's good. Oh yeah. That's time to start. No, you're fine. All right. Is it warm in here or is it just me?
I think it's just you. You've been running around.
Okay.
Yeah.
All right. And I started drinking some coffee made by Dr. Newville, which is another pharmacist here. So thank you, Dane, for my coffee. Yep. Actually, I'm just going to put these out and then whoever. There we go. Actually, I know, yeah. If they don't show up, honestly, when we do these seminars, I think I get about a 50% return rate on these.
Really?
Yeah.
You would think I must sign up.
It's $10 free, right?
Yeah,
I mean, if you take a vitamin, I mean, we got plenty here. Save the $10, right? I'll put one over here. All right, we are going to get started. I've got about an hour of material, but since it's just a small group, I want to make this really interactive. If you have questions, just stop me. I really want you to, my take home is to make sure you obviously understand the information and then can apply that to yourself, a family member, whomever. And so if we need to spend more time on one specific topic, we will. And if it's everything that we know already, we can just breeze through it and go on to the next thing. So, all right, without further ado. So, my medical disclaimer, since I am streaming this to, well, even if I wasn't, but because of the internet and YouTube, I always want to say I'm a doctor of pharmacy, but I'm not a medical doctor, so there's a difference there, of course. So I can't stop your medication, I can't start medication, I can make recommendations to your physician, and that's what all this says. And everything said tonight is for informational purposes only. Before you start any type of diet program or any type of supplement, my opinion is always going to be to check with your provider first, with your physician. So that's what all that is about. So here's just a brief summary of what we're going to be getting into tonight. So we want to make sure we know what we're talking about, even DNA and genes and genetics and epigenetics. How does that all interface with our weight and so forth? And then we talk about genotyping technology, which we're probably going to skip over, to be honest with you. It's the meat and potatoes of this talk is really like, what do I need to do so I can lose weight? It's really my focus. And what kind of vitamins do I need to take? What am I predisposed to as far as am I more of a meat eater type of genetic makeup or plant-based, or what? This test will help determine those, answer those questions. So yeah, there's a lot of applications. I will show you probably once we're done with the live stream, my own report. It's 100 pages long. We're not going to have, if you guys want to stay here all night, I have nothing planned tonight, so I'll probably get really tired around 11 or 12 o'clock, but hopefully we don't go that long. But if we need to, we can. But there are so many applications. There's 100 pages of material that this test provides. I can't mention it by name either, so we'll do that after I shut off the live stream. So I'm going to talk in generalities about the test and what it can provide, and then afterwards I can give you the name of the company and all those kind of things and who we use. So just apologize for that up front. And then how can we use this test to help our health, live longer, live a more fulfilling life, I'm always talking to the patients here and even the staff about we want to not just we want to add quality to the lives we're here, right? I think we all know that. So it's not just the quantity or the number of years here. So yeah, how can we use this test? So I got a lot of pictures. I think with genetics, it just kind of helps to make more sense to have some more pictures involved. But you get a set of your genetic makeup from mom and another set from dad. So when you have like my red hair, right, like recessive genes and so forth, so you get a blend of sometimes two of your genes, or sometimes you just get one that's dominant, so things like that. So we'll get into all of these genes that this test is measuring. There's 384 of them. And what does all that mean? And you have 2 copies of each gene, so which one is expressed, which one isn't. Kind of have to go through all of that to make sense of it. And then we're going to start talking about, when you really get down into our genetic makeup, if there's these mutations that's starting to pop up. And that's the term we use. I mean, maybe it's, and it seems like it's a negative connotation that, oh, it's mutated, something's wrong with it. Well, I'll use an example of sickle cell anemia, where they have oddly shaped red blood cells, and that's mainly found in people that were in Africa. And I haven't looked at this in quite a while, but there's evidence to suggest or point towards the fact that sometimes those patients with sickle cell anemia are less likely to contract malaria or have the negative consequences of when they contract malaria. So sometimes what we think of as a mutation in a gene, like we'll talk about MTHFR and methylation, well, maybe there was a reason why that gene actually mutated. We just haven't figured it out yet. So to kind of keep some of these things in perspective. So, yeah. So, all right. So the basics of genetics. DNA contains information. If you think very simple terms here, right? It's just, this is a genetic code to build proteins. A lot of them. We have depends on what research you look at, between 19,000 and 23,000 genes to build proteins. There's a lot of things being built by our DNA. So it's literally just information. So how do we build all these proteins? DNA basically tells our bodies, tells the machinery in our cells what to build, how to build it. So we got 23 pairs of chromosomes, again, half from mom, half from dad. Again, I just mentioned this, I get ahead of my slides, I apologize. Again, between 19 to 23,000 genes in the human genome. And I just put some kind of fun facts here. I mean, dogs and cats have just about the same amount of genes as we do. Octopus have a little bit more, they have 33,000. Isn't that interesting? And then tomatoes, a regular plant, has even more than the humans. So what are all these genes doing? They're just, again, these genes are just genetic code for making different proteins in our body. So, all right, so protein, there's a typo there, sorry, proteins. But what are proteins doing? Let's just kind of scale it back, 10,000 foot view. They're needed for life, biochemical functions. We have proteins that are doing all types of things in our body. Obviously, we eat protein, right? Break down protein down into amino acids, our basic building blocks, and then we rebuild them into what we need, skeletal function, muscle function. But proteins are also enzymes. So we do a lot of hormone testing here in thyroid. There is an enzyme in our body that converts T4 into T3. Well, that's a protein that's coded by our DNA, and if that part of our DNA, we'll call it a mutation tonight, is mucked up, you may not be able to convert T4, which is inactive synthroid, into activated T3. So you might be diagnosed with hypothyroidism because your TSH is high. Your doctor puts you on T4, and you don't have the protein or the enzyme to convert 4, which is inactive, to active. So that's just one of thousands of examples that I have of, like, what is our DNA doing? It's building these proteins. These proteins are enzymes. You could have a malfunctioning enzyme like the MTHFR. You don't methylate B vitamins well, and then so you need to take a methylated B vitamin because your body can't do it. It's got a mucked up gene, a mucked up protein, a mucked up enzyme to do the conversion. So, but then proteins could be as simple as transporter proteins. I'll use the example of the thyroid patient again. So you've got to get a signal into your nucleus of your cell to activate the genes to then make the proteins. You might not have the right transport system to get T3 that's outside of your cell inside the cell to cause action. So it might not be that you can't convert 4 to 3. You might have enough T3 around and your labs look good. You might not have the protein that takes the T3 that's in your blood and has to shuttle it inside every cell of your body. So you could have something mucked up there too. So there's a lot here to go through, but I don't want to overwhelm you too much. But anything and everything in your body is controlled by our genetic makeup. So for the most part. There's exceptions there, but just think about that tonight in that regards. Structural function, so hormone receptors, I just kind of talked about this. You might have enough thyroid hormone in your body, and the receptor that's outside of your cell, I like to use the example of osteoporosis, and we do a lot of estrogen treatment here. And let's say you have osteoporosis, and again, some of the more common causes, you don't have enough calcium, you don't have enough vitamin D, you don't have enough vitamin K2. Maybe you just don't have, maybe the receptor that's on those cells that is activated by estrogen is faulty. So now you can't activate the switch using estrogen to build bone because the switch is broken. So it could be something as simple as that too, that you can have this, again, genetic mutation, and now your doctor thinks, oh, you have osteoporosis because of, again, maybe you're not getting enough calcium, rule out all of those possible issues, but if you've checked all those boxes and that's not it, it could be a genetic deficiency.
So I know this might not be the right time to ask, but what type of treatment do you do for the osteoporosis here?
Oh, God, very simple.
If I ask that way.
No, let's do it now.
Okay.
Vitamin D,
Yeah.
vitamin K2, and then minerals. Typically magnesium over supplemental, yeah.
Okay.
Magnesium over calcium in most cases.
Okay.
And then collagen, and the list goes on. But those are my main three.
Okay.
Yep. So, and then hormones. Antibodies. So we're looking at a great example with COVID was that there were patients that you drew their titers, they had COVID, but they didn't produce the antibodies. Maybe they didn't have the genetic information to actually make the antibodies to go and attack the virus, or whatever you want to call it. Some people don't think it was really a virus. I mean, maybe that's not a good example to use. So, does everyone believe in the influenza, like flu? Yeah. Or chicken pox? Yeah.
I'm probably getting ahead of myself
No.
here too, but would this test actually be able to pinpoint the enzymes and the transporters and the any antibodies that may not be functioning as
Not in this specific test.
no? Okay.
I'm sure that's to come. We are at the tip of the iceberg with genetic testing. So I'll go through all so tonight's just going to be is going to focus on weight loss and that type of thing, and vitamin assimilation and utilization and things like that. It won't get into the immunology side of things, but I'm sure if there's not a test out, I don't know of one yet, but I'm sure if it hasn't already been created, I'm sure it's on its way. Yeah. I mean, and then again, big picture for me too, in our pharmacy, it kind of jumped ahead, but now might be a good time to, we're talking about personalized medicine, and I think that's where the future of medicine is going, is individual, not just one size fits all, we all just get, whatever, the same strength of it, or maybe we have like a statin drug and it comes in 4 different flavors, We're going to be learning more with genetics. My opinion is just, we're going to be able to take a patient, screen them genetically to see which medications that are going to be most effective for them, I'm not as a pharmacist, those of you that know me already, I'm almost like an anti-drug pharmacist, if that even makes sense. I'd rather use a supplement or diet, lifestyle, something other than a pharmaceutical, and screen that patient genetically and see what is most appropriate for them. We actually have that, and we're not going to talk about that tonight, but in a different genetic test that we offer. So, and proteins have, again, many, many, many more functions. We can talk about proteins all night, but we got to keep moving on. So back to genes. Again, let's just say, make the number easy. We have roughly 20,000 genes, and each gene contains 2 copies, which in the genetic world, they call them alleles. So, but we have 2 copies that make the same protein. And it's alternative forms of the same gene, so same information, with small differences in DNA base pairs. So hold on to that thought, that is explained in the next slide. And again, you get 1 allele, 1 copy from each parent. So which one's expressed, is one faulty? There's a little redundancy in there. I kind of like that, actually. God had something gets mucked up, we got an extra copy here just in case. So. Genetic variations. So we talked about this already. These mutations is what we call it. Genetic variations are caused by mutations. We call them mutations. what's a mutation? Could be taking an antibiotic, can cause genetic mutations, possibly. We all know toxins, heavy metals, pesticides, herbicides, xenoestrogens. The list goes on and on and on. There's a lot of things that can, dysbiosis in the GI tract. But we can inherit them, and then we can acquire them. I was kind of going into the acquired side of things, but Down syndrome, different things like that we all kind of know of, that are mutations that are obvious, more obvious. So some of these things we can again inherit. But maybe I missed this in like freshman year of high school when I first learned about genetics. In my mind, when I first learned about genetics, it was more like your DNA is your DNA and it's set in stone. You can't change it. And that's simply not the case anymore. So we know that environment can, you can take an antibiotic, can change something in your DNA that you can pass along to your offspring and not even know it. And there's studies to prove that. Or say, I shouldn't say, prove is a strong word, suggest, it suggests that. So we have to be, I think, more cognizant of our environment and how that influences our genetic makeup. So these are these SNPs that we're talking about, these single nucleotide polymorphisms. It's basically just where there should have been, and this is just one example. I'm not going to get into the whole nucleotide talk tonight, but just know that this is where these mutations come from. Geneticists can get down, and that's what this test is going to look at if you do it, is that it's going to identify what the norm is, like going back to the MTHFR and methylating your B vitamins. It knows the sequence of these nucleotides and what their order should be. And if one letter is off, one piece of information is not the right one, now you've got a mucked up protein. So that's how they actually identify with our blood test. Do we have these mutations or not? They can actually get down to the, think of it like binary code, zeros and ones. It's actually like 0, 1, 2, 3. There's 4 different base pairs. But it can get down to that specific of information on our DNA now to know, do we have this mutation or not? And then do you have the mutation in your gene from your mom or your dad or both? Because if you have going back to the methylation with B12, if you have that SNP, that mutation in both copies, you're kind of screwed in that regard. And so now you really have to take methylated B12. So maybe. So I don't want to get too, and part of it too, I think there's enough ingenuity in the way God designed the body that maybe you've got this SNP and this mutation, but maybe there's a workaround that your body's already figured out that you don't. Maybe you've upregulated your glutathione production. Who knows? I'm just hypothetically, maybe that possibly could be happening too. So again, we got to keep all this in. I think there's too much still unknown that what I'm presenting tonight, I just don't want to take this as the gospel quite yet. So 4 key points on these mutations. So these SNPs, these mutations, are the most common type of genetic variation. There's over 10 million SNPs, or these, again, single nucleotides that are in our genome. SNPs can affect, we just talked about this, if there's a mutation there, it's going to affect that protein function. So if you don't have that protein, that enzyme that methylates B12, we now have a potential problem here. So knowing your SNPs can help to predict individual response. Here we go. This is the brass tacks, what does this mean to me? Knowing what those SNPs are, which is what the test will identify, in both of your copies, because you got 2 of them, your response to medications, to vitamins, foods, and much, much more. There's 100 pages of, again, 384 genes that this test looks at to say, should you eat fat? Should you eat more carbs? Should you exercise? Should you not? Should you take more vitamin D? How well do you metabolize caffeine? How well do you metabolize gluten? How well do you metabolize alcohol? What's your predisposition to diabetes? What's your predisposition to high cholesterol? On and on and on and on and on. So, if you leave with one thing tonight, because a lot of this can be overwhelming. You're like, where do I start? Where do I go? Do I just stop eating everything that I have in my pantry tonight? No, don't do that. Knowing your SNPs, again, knowing your mutations can help predict individual response. again, to these drugs, vitamins, foods, and your predisposition to health conditions. So it's not that this is like a life sentence, like, oh, I have all the mutations for poor glucose metabolism, so I'm going to be diabetic. That's not what I'm saying. You're just going to have to work probably a lot harder and eat less carbs than the person that doesn't have those genetic SNPs. But this is kind of like step one. Once you kind of learn basically everyone has their own rules for their game of living life and how healthy they are based on their genetics, and you think of it that way. And so once you know the rules that you have in your own biochemistry, then you can start playing the game. And I'll show you that with my report once I'm done with the live stream. So, all right, so, oh, look at this. The point of no return. So once you learn this information, you're not going to be able to unlearn it. Okay, just so we're aware of that. But we talked a little bit about this just a few minutes ago, but the impact of our lifestyle habits can modify gene expression or function. So again, back to freshman year in high school, in my mind, maybe my professor, high school teacher told me different, but I don't think we knew that. Actually, yeah, I don't think epigenetics. I was a freshman in 1993, so I don't think we knew epigenetics wasn't probably around then. So whether you exercise, smoking or not, drinking, I think this is my icon for drinking alcohol, eating cruciferous vegetables or not. Some people are sensitive and they don't want to eat cruciferous vegetables. In some patients, we want to eat more of them because it helps metabolize estrogens out of our body more, and we don't accumulate estrogen. And then we eat more of that, and we can potentially lower our risk for breast cancer or any type of estrogen-related cancer, possibly. How well do we sleep? I forgot what this icon was. Our stress level, maybe, and then how much, even vitamins can influence our epigenetics. Our gene expression. Does something get turned on or turned off? So applications, let's get into this a little bit deeper. So it can help diagnose disease, or going back to the MTHFR mutation, can help, do I need to supplement with methyl B12? Because I got both of them over here, and the methylated B12 is more expensive than the regular one. So it can kind of help define not disease, but conditions, and diseases, of course, too. But here's we're going to talk about analyzing your metabolism. Are you a fast metabolizer or a slow metabolizer? There's genes that predict that, and I'll show you that on my test. I'm a fast metabolizer. Yes. So, yeah, but on the downside, I have genetic SNPs where I can exercise and I won't lose weight. So I've known that if I run. Not that I hate running, but if I did for a little bit in college, I never lost weight, ever. It just made me more hungry and I just ate more. So, but again, now I know the rules for my own game and my metabolism. So this is I kind of nerd out on this, but selection of treatment for which, again, hypothetically, but if I were to recommend, an SSRI for depression, are you better off using, Prozac versus Effexor versus, whatever drug? So, or which statin do you respond better to? Or another one is for blood pressure pills, how many blood pressure pills are out there and how many different classes of blood pressure pills are out there? Or even let's get down to, I was at a fundraiser on Saturday for pancreatic cancer. They can actually do genetic testing now to see which chemotherapy drug you are better suited for based on your genetic makeup. Is this pancreatic chemo drug going to work for you? Well, now we can start to test you first to see if you're going to be a responder to that. So, again, tip of the iceberg kind of stuff here. And again, but tonight is more about optimizing diet and lifestyle. So I don't have to go home and run 3 miles tonight because it's not going to matter anyway. Well, it will. It won't for my weight. It will for my cardiovascular health in that regard and my lung capacity. But if my goal was just to lose weight, I'm better off lifting weights. Oh yeah, I apologize. I was trying to get rid of the animation there with my little icons, but all right. Nutritional genomics. So factors that promote obesity, this is not an all-inclusive list, of course, but just for tonight. But genetics influence whether we gain weight or lose weight. Energy intake and diet type, we'll get into that a little bit more tonight as well. Again, are you better off with a ketogenic diet? Should you eat more fat? Should you eat more protein? Is it a carnivore diet? Should you eat carbs? How many should you eat? 100 grams a day, 50 grams a day? So this test can help decipher that out. Physical activity, talked about this already. This test will tell you if you're predisposed to losing weight while you do aerobic exercise or not. So, hormones and medications, we'll talk more about that. Obviously, breathing. This sounds too good to be true, but just if you don't breathe well, if you don't oxygenate well, you're going to have a much harder time losing weight. So that's kind of like number one. Like if you are a mouth breather, get that figured out. Figure out why that's happening. Get to the root cause of that. Do you need to wear a CPAP machine at night? What is it? Is it sinus congestion? If we're not exchanging oxygen well, can you still lose weight? Yes, but it's going to be much harder to do so. So this genetic test doesn't tell us that, but I don't want to leave that out. But breath work is important. Learning how to breathe appropriately, getting into your parasympathetic nervous system, controlling your breath. I mean, there's all kinds of videos out there. Does anyone know Wim Hof? No? Okay. No. But Iceman, he has this. If you go on YouTube, you can check him out. W-I-M, so Wim, and then H-O-F. He's got a bunch of books out there that he's written, but he's really perfected ways on how to help with breathing techniques to help improve your immune system, just to rest and relax, all those kind of things, sleeping better, focusing better. So how does all this really work? I can sometimes laugh at my own slides. All right, there's a study, evidence-based medicine, right? Like, there's not a lot of great studies out there, to be honest with you, so some of the stuff is limited. Again, tip of the iceberg kind of stuff still. But so improved weight management using genetic information to personalize a calorie-controlled diet. So what they looked at here, there was it wasn't a huge study. 43 patients in the control group. Did I say that? 43 patients in the control group, 43 patients in the treatment group, and what they got was a variation of the genetic test that we offer here. Not the exact same one, but it did look at genetic SNPs related to weight and how they metabolize foods and things like that. They followed them up after 300 days, and so this is rather impressive though. So those that got the treatment, which was just basically this genetic test, and then they were told how to eat based on their genetic SNPs, they maintained weight loss. 73% of them, of the 43, maintained weight loss, compared to the control group, only 32% maintained weight loss. And their average BMI reduction in the treatment group was a 5.6% loss in their BMI, compared to the control group that actually gained 2.2%, and that was clinically significant, or statistically significant. This part interesting. Actually, I have this summarized, I think, on the next page. But they had better compliance to their diet changes. So if you know the rules of, again, should you eat more fat, should you eat more protein or carbs, if you're told that, you were more likely to follow that diet, because you're like, oh, my genetics say that. I should probably follow what my genes are trying to tell me to do, right? Long-term BMI reduction was clinically significant. I mentioned that, or statistically significant. More likely, I did mention that too, more likely to have maintained weight loss after 10 months. Next page. Oh, there we go. More results. Fasting glucose, this is what I found fascinating. Fasting glucose levels in the study group versus the control dropped 20% more. And these numbers don't seem like a big drop, but when you're looking at, glucose levels of, usually when you do a fasting glucose level, your doctor wants it under 100 typically. I like to have it under 90 ideally, in my opinion, of all the research I've looked at. The lower that number can be on a fasting level, ideally the better off you are. Not in all cases, but in general, better off metabolically metabolically, in my opinion. So just even a slight difference, a little nuance there, but they could have a profound impact on your health and keeping weight down. So small improvements in weight loss biomarkers can have a significant impact for the reduction of disease, such as cardiovascular disease, diabetes, and even metabolic syndrome. So sometimes the devil is in the details here. Even just having a slower or a lower fasting glucose level can be beneficial. So again, I can't mention it by name, but the test that we have, it's to date that I know of anyways, it analyzes, like I said before, 384 genetic variations related to more than 50 nutrigenetic categories, which is that 100-page report that I'm going to show you after we're doing the live stream. Three advantages here, three key advantages. It does an integration with epigenetic factors through lifestyle questionnaire. So there's like a 3-4 page questionnaire that they want you to fill out. Not that that's going to change your DNA, obviously, but they just like to help do some epigenetic questions. Personalized diet recommendations. There's over 900 different, like, what do you eat? You know, after I tell you that, yeah, sorry, carbs aren't for you anymore, they will give you a whole list of foods that you should or recommend that you focus on, and those that you should probably stay away from. They categorize it kind of like a stop and go, like a green is good, and then there's like yellow light, like yellow and orange light, like moderate to light, and then there's the red light, which is like, no, don't eat any of those foods. So they give you a nice booklet to take home and study. Like, okay, now should I eat this? Should I have olive oil or coconut oil? Should I have red meat or should I have chicken? Should I have broccoli or Brussels sprouts or potatoes, sweet potatoes, dairy? I mean, it goes through 900 different foods. And it's not that, again, it's not like absolute, so like you can't have if something's like a red. It's just like, you just have to know now. That's probably not that consuming that food product's not going to be great for you. And then it does go through personalized supplement recommendations based on genetic and epigenetic data. So we'll go through a little bit through that too. But like, it'll look at these DNA SNPs, these genetic SNPs, and say like, how well do you assimilate calcium? How well do you assimilate and utilize magnesium and vitamin E, vitamin C, vitamin D, and I think there's about 12 or 14 different vitamins. It doesn't do everything, but it does a fair amount of them where you can start to say, okay, oh, that makes sense, that makes sense. Like I have 3 out of the 4 genetic SNPs that I don't assimilate magnesium well. I can take the magnesium that we sell here at like the dose of literally the quadruple of most people and not get any diarrhea. Not get any diarrhea. Like, so if you take too much magnesium, typically, yep, you'll get that. I can take like 4 capsules. I'm good. It explains why I get muscle cramps all the time. If I don't take my magnesium, that's one thing. Like, oh yeah. So you start to kind of, after you get the test done, you start connecting all these dots. You're like, oh yeah, that's why. And oh, that makes sense now. Yeah.
So, supplements that you may be taking when you take the test, is that going to affect any of the outcome at all?
Not typically, no. Right. Yeah, that's a good question. Yeah, but and then going back to my magnesium example, it didn't test my magnesium level. Like, so once you know the rules of your genetics with your SNPs, now you have more homework to do. This is like test number 1 of many, because now you have to go back. What is your magnesium level? Are you getting enough? Your genetics say that you don't assimilate it very well, you don't absorb it well, and you don't utilize it well. What is your level? So then you got to go back and look at that. So that's where, again, this is really like, it's not. This is a genetic test. It's not like it's predisposing. You see what your predisposition is to diabetes. Well, now you got to go and test your A1C, or you should, and then you should probably go and not only do a fasting glucose test if you're worried, but now you should go get a fasting insulin test. That's a lot of patients that come in here. They're asking about diabetes, weight loss, glucose control. I always ask them if they have a fasting insulin test, because that's, in my opinion, it gives us more information. When I used to do diabetic training, you could kind of cheat the system and test your blood sugar when you knew it was low, and you'd get good glucose numbers. But the real telltale symptoms tests are doing the hemoglobin A1C, because that's like instead of a snapshot, it's like a 3-month video condensed into one test. And then The other test is the fasting insulin level, because that's, in my opinion, if you have too much insulin, you're working too hard to putting those carbs into storage. So usually I say when the body consumes too many carbohydrates, then it's going to release too much insulin. When the body releases too much insulin, it's game over for weight loss. Now insulin, just think of insulin as the weight gain hormone for adults anyways. In adolescents it's different, but in adults, if we're pushing out too much insulin out of our pancreas, we're going to have a really, really, really hard time losing weight, because insulin is the weight storage hormone.
Is
So,
that what metabolic syndrome is?
pretty much, yeah. You get insulin resistance, so then you have all of this insulin, and it's going up to the receptor on every cell in your body, knocking on the door to open up, and it just won't. Or it opens up really slowly. And then you test your blood sugar, and it's 200, right? Or 150, or things like that. So, yeah. But again, this test will then, I think it looks at like 12, no, more than that, maybe like 15 different SNPs related to metabolic syndrome and diabetes, insulin resistance. So, how am I doing on time? Am I on? Oh my gosh, I've been yammering for 35 minutes. Any questions? Okay, keep going? All right. So they do break, the test does break this down into certain categories, so I just want to go through this, because this is where it starts, again, getting into what is this test really going to give me? What is it going to help me with? So gives you your genetic risk of being overweight or obese, your risk of rebound weight gain. That's interesting. I see a lot of people, they'll lose weight and then they'll gain it right back. Lose weight, gain it right back. Lose weight, gain it right back. So we can actually look at specific genes in our DNA to tell us, how much of a yo-yo dieter are we going to be. Helps us with our basal, again, gives us, and there's ways to change your, if you exercise all the time, you're going to have a better basal metabolic rate. But genetically, what are you predisposed to? Do you burn calories quickly or not? That's going to be important to know, or could be. Weight loss capacity on diet intervention. So again, if you're going on a ketogenic diet, what's your chances of that being successful versus what are your chances of just doing a balanced diet with, average amount of carbohydrates? So it looks at behavioral genetics. So like, are you predisposed to having an issue with food where, you crave foods, you crave sweet? It actually looks at, there's different genes that predispose us to being, craving salt and craving sugar. There's actually, this test will look at that. Or just like your behavior, like are you more apt to, be bulimic or have a food disorder? There's that too, that it looks at. It's not by any means perfect, but it just gives us an insight, saying, hey, we should maybe look more into that. Talked about the efficacy of physical exercise already. It helps, if endurance exercise and HDL levels. It looks at SNPs about exercise to reduce body fat. This is where I had this, I got malfunctioning genes related to that. Like I can exercise all day, every day, and my body fat won't go down because of that. If I gain muscle, then my fat will go down. Looks at fat metabolism. So like we have specific genes that predict if we are better at monounsaturated fatty acids, if we can break those down more effectively, so like our olive oils, or like how we respond to polyunsaturated fatty acids, so like your omega-3s, your omega-6s, your omega-9s. And then your response to fat intake to improve HDL levels. So if you go on a ketogenic diet that's 80% fat, which we see, you can look at this in the HDL levels. Well, actually, they go down at first. If within the first 3 to 6 months, your cholesterol looks horrible on a ketogenic diet, generally speaking. But once you get past that, usually 6 to 9 months, maybe even a year out, and if you're still on a ketogenic diet and following all the rules, your cholesterol actually can improve quite greatly and look better than you were on a standard diet. It looks at CHO, that's short for carbohydrate. So it looks at carbohydrate metabolism, your ability to digest starchy foods. So should you be eating potatoes, every night? And your sensitivity to sugar. And if you eat carbs, how is that going to impact your HDL and your LDL? How are, again, eating in, let's just say, a 30% diet or 40% diet of of carbohydrates, is that going to make your HDL worse, better? And then what is that going to do with your LDL levels? Sorry, that got cut off there at the screen. And then it looks at lipid metabolism. What's your predisposition to having a low HDL? I got to look at that again. My HDL has never been good. The only time my HDL got into better numbers is when I was on a ketogenic diet, and then my HDLs finally got into an acceptable range. What's your predisposition to triglycerides? What's your predisposition to oxidized LDL? If you're going to be getting, in my opinion, LDL is antiquated. It's old. Like, if you just go to your doctor and get this is again my opinion, your total cholesterol, your HDL, and your LDL, who cares? Like, LDL in and of itself is not bad. It's the inflammation that starts in your arteries that then, you get this this inflammation of the arteries. You get this, basically, I think of it like a cut or a wound on the inside of your arteries, and that sparks cholesterol to come in and basically lay down and smooth over that rough patch. And we claim that it's cholesterol that's the problem because it's like guilty by association, right? Like, it was there in the clot that, formed in your carotid artery, and now you had a stroke, or it was in your heart, and so that's a heart attack, and LDL was found there, so it must be bad. Maybe it was there to kind of smooth stuff over, from the initial, again, root cause of why did that area of your artery on your heart get irritated in the first place. Maybe we should be asking that question. So I digress there, but you should be looking at oxidized LDL. That's what the OX stands for. Oxidized LDL, that's problematic. Ask your doctor for OX LDL on your next cholesterol test. That would be a better predictor in my book if you're at risk for cholesterol building up, plaque building up in your arteries. And there's research to support that. I'm not going to get into all that tonight, but. And it goes on and on. So there's so much here. I'm going to go through this, but glucose metabolism, risk of increased glucose levels after fasting, your risk of insulin resistance, it looks at that, your risk of type 2 diabetes. Talked a little bit about this, but there's genes that, are you more sensitive to bitters or salt or sweet? It looks at that as well too. Like, oh yeah, I always crave salt. Well, why is it? There could be more than one reason, of course, right? But maybe you're, again, genetically predisposed. Disposed, thank you. I can't talk anymore today. And then detox imbalances, so like going back to vitamin C and glutathione or methylation, they have, this is the weight loss kit. There's another kit we have that just looks at, I can't remember how many genes it is, but just related to methylation. But this looks at a few of those detox pathways, not all of them, and it kind of helps gauge your antioxidant capability, like how much vitamin C should you be taking, how much vitamin E should you be taking. Again, it doesn't give you levels, but it gives you, again, maybe you need to look more into that. We talked a little bit about this already, calcium absorption, calcium balancing, iron toxicity, risk for low plasma iron risk, magnesium balance, selenium, sodium. So it looks at a lot of these different minerals and electrolytes to see, again, maybe you're very sensitive to sodium genetically. And then intolerances, it looks at specific genes to let you know if you have lactose intolerance, if you metabolize alcohol well or not. Gluten or celiac disease, it looks at certain SNPs there, caffeine metabolism, which I am horrible at. I have all 4 marks. I don't metabolize caffeine very well at all, but yet I still drink it. But I would sleep a lot better if I didn't drink it. But and then fructose intolerance as well. So how well do you metabolize fructose sugar? So should you be eating an apple and a banana every day? And there's more. Vitamin deficiency, again, this is vitamin deficiency risk. So when you get your report back and they list all these different vitamins, it's not blood levels, it's just, again, what's your risk? And so I was at high risk for low vitamin E and the magnesium on the other page, so I got those levels tested. I was low, I started to supplement. So that's kind of the utility of this test. It kind of helps direct you and what, got a lot of vitamins here. You don't need them all. Let's figure out what you might be predisposed to, then go and do that specific test and then treat appropriately. Matching diet type. Flip that around, sorry. Efficacy of a low-calorie diet. Some people do better on low-calorie. Most of the people that I've tested, that have gotten the test from us and I've consulted with them, I would say 90% of those reports that I've reviewed, we don't do well on a low-calorie diet. So yeah, that drives me nuts. All my and I've heard it time and time again from patients, oh, so-and-so just told me to eat less. Well, if you're genetically predisposed to a poor efficacy of a low-calorie diet, why would you put somebody on a low-calorie diet? Then you're going to put them into the starvation mode. And then your body is just going to want to, Now, I mean, it doesn't say I'm not saying that intermittent fasting is bad and fasting in general is not good, but, the day-to-day, we probably shouldn't be eating just 1,000 calories a day or 1,200 calories a day. So it does help to give us a better idea of how many calories we should be consuming. Efficacy of a low-carb diet, efficacy of a low-fat diet, and then it even looks at inflammation risks, so like TNF-alpha, which is an anti-inflammatory marker, IL-6, so interleukin-6. Again, if you have a lot of inflammation in your body, and you can actually measure these levels now, your doctor can measure those. I can't measure those here. We don't have that test yet, but you can, there's other labs that can do it. You might just be predisposed to that. So that's something that, again, this is just kind of test number one and just can help lead you down different paths to figure out if you're struggling with certain inflammatory issues in your body. And then hormones, like, are you sensitive to leptin and these hunger hormones and ghrelin, adiponectin? So how, do GLP-1, like the semaglutides of the world, that's a big hot, drug right now, and Ozempics of the world, and all these weight loss drugs, all these injectable drugs that are getting a lot of sales out of them, a lot of patients are on them, but maybe they just don't respond to a GLP-1. Maybe they've got, again, that's a hormone that we're injecting into people, and we're assuming that the receptor that is supposed to turn on their metabolism, basically it's just turn off their metabolism, right? So they're not hungry, their GI tract slows down, so they feel full because nothing's moving, right? That's how those GLP-1s work. But it's maybe their receptor for their GLP-1 hormone that they produce on their own just isn't working. So the switch never gets turned off, so to speak. Switch doesn't work the way it should. And then it looks at what's your predisposition to being overweight. There's all of these genes that are analyzed, not that they go through them, but it breaks all these things down, like reduced resting metabolic rate. If you've got these SNPs, then you're predisposed to, again, burn more or less. So if you have the SNPs, then you're going to burn less calories while resting. Increased BMI. If you've got mutations here, then you're going to be predisposed to a higher BMI. There's these specific genes. If you inherit those SNPs, then that's an inherited risk factors that lead to being overweight and obese. Weight loss capability on diet interventions. So again, if you go on these diets and you're going up and down in weight, is that a good thing or not? So is your body able to recover from those kind of things? Or weight recovery after diet intervention. So are you going to, again, rebound effect? Are you predisposed to regain weight after dieting? Because if you are, then you got to be, especially these patients that are coming in for semaglutide, if they do this genetic test, what's going to happen when they stop their semaglutide? There's already tests out there now. Dr. Stewart that works here one of the pharmacists, he's got a study, I haven't read it yet, but something to the effect of, I think it's 30, don't quote me, but 20-30% of the patients, might even be more than that, that stop semaglutide, they gain the weight they've lost plus more. So, yeah. Are you going to be on semaglutide the rest of your life? I don't think that's a reasonable solution for most patients. And this test goes on and on and on, but it looks at HDL, LDL, cholesterol. Here's your LDL oxidized level. So your cardiovascular risk increases due to LDL oxidation levels. So if you're making more oxidized LDL, and if you have that predisposition, I would encourage you to go get your oxidized LDL tested, not just your LDL.
And what can you do to lower that if you have, I mean, like what would you?
There's certain, great question, there are certain supplements out there. Basically there's antioxidants, very specific targeted antioxidants that you can take that have been, again, got to be careful with the word proven, but that indicates that if you take these certain antioxidants, you'll reduce your oxidized LDL level. And I'll share that after the live stream. It's sitting over here. Yeah. So, and then triglycerides and your ratio and so on and so forth. So they've got all of these genes marked. So, and it goes on and on. Fasting blood sugar. Like, are you going to have a predisposition to higher glucose levels? That'll help us see if that tendency is there or not. Here's those genes. We got 1, 2, 3, 4, 5, 6, 7, 8. Whatever. Is that 8? I can't count anymore. 4, 5, 6, 7, 8. Genes that are going to tell us if we're at higher risk for inheriting type 2. I have about half of them. Damn it. So my dad's type 2 diabetic. I don't know if my mom is, but again, now I know the rules. I'm like, I better, if I want to stack the cards in my favor, I'm going to exercise, I'm going to sleep, I'm going to do all the right things. At least I'm going to. Now, not that I wasn't before either, but yeah. Or what's my risk for insulin resistance? So, yeah. So for me, yeah, stay away from sugar. Scary, right? Most addictive drug in the world. Or if you want to call it a drug, right? Food. Vitamin deficiency risk. So I had the vitamin E issue down here. I had the SNPs on, I think both of these genes I had mutations. So inherited risk of vitamin E metabolism deficiency or low plasma levels. It looks at your vitamin D deficiency risk. Again, it looks at vitamin D metabolism deficiency and plasma levels, vitamin C, your B vitamins, vitamin A. So again, if you know that then, and I don't know if there's a blood test for all of these, but we all know probably vitamin D. You can go get a simple vitamin D test. I don't know if vitamin B12, you can get your B12 level tested. Some of these I'm not quite sure of, but the point is if you have this deficiency, go to the next step. Figure out if you need to supplement or not. Eat more, or I always say supplement, but we all should, in theory, right, beginning, if we have a deficiency here, we do a blood test and we're deficient, we should be focusing on foods, in my opinion, that contain those vitamins and nutrients. And then at the very, if that doesn't work, then okay, let's supplement. Your exercise predisposition, so exercise to reduce body fat. This is where I think I had all 3 of these were totally messed up. So I just ain't gonna work. Endurance exercise for increasing HDL. I can't remember what my level was on that, but it'll look at that too. So, in conclusion, your genetic predispositions are not guaranteed outcomes. So even though I have half of my genes that this test looks at that are mutated for predisposition to diabetes, doesn't mean I'm going to get diabetes. It's just, right, it's just helping to say what is your risk. It's not a guarantee. So, as it says there. So, I think that is all I've got. Contact information, that's mainly for the people that are watching at home that'll watch this later. Email is the best way to get a hold of me, or call in the pharmacy. I'm not if you're not in my contacts, I'm not answering your call. You can text me and tell me who you are, and then I'll, get hold of you that way. But yeah, don't call me at like 2 in the morning. Should I eat this ice cream? I'm really got some cravings right now. What should I do? I'll be like, go to bed. You need sleep to lose weight. Rule number 1. All right. There's that. Free consultation. So anyone that sees this, even on the live stream, you can order the test. Oh, actually, you can't. You have to call the pharmacy. Long story short, we can't sell it on our website, so you can call us and order the test kit. Mention the genetic weight promo code. You'll get a free consult. It usually takes me, honestly, about 2 hours for us to go through 132 pages of genetic SNPs. There's a lot of information. So I've done enough of these where it is, in my opinion, is very insightful. It gives the patient a very strategic game plan of what they should and shouldn't be doing to help maintain proper weight. Plus some, like even vitamins, and what should my macronutrients be? What percentage of my macronutrients on a daily basis should be fat versus protein versus carbs? We go through that. How many calories should I be eating in a day? So should I be taking berberine and dioxanol and chromium and all these supplements to help lower my blood sugar? Maybe. Should I be exercising? What kind of exercise should I be doing? How much of it should I be doing? So it helps to, again, kind of set you up, again, to know the rules that your body is playing with, so then you can make some better informed decisions. So, oh, and that is it. Go back to page 1 here. I'm going to shut off the live stream, and then I'll show you this test. And then we can talk a little more freely too, and be more specific on things. So.